ankle fractures in children. The incidence of growth arrest following physical ankle injury can be up to 50%. This is the Salter-Harris classification of ankle fractures. Type 1 and Type 2 Salter-Harris injuries of the distal tibia usually do for them close reduction and casting. If you operate on them, that does not decrease the incidence of growth arrest. Type 3 and Type 4, because it involves the joint, you will do reduction and fixation of the fracture. You will do epiphyseal screw parallel to the physis, or you put metaphyseal screw if you have a large metaphyseal piece in Type 4. When you do the fixation, avoid violating the joint or the growth plate. The highest rate of growth arrest in pediatric ankle fractures will result from medial malleolar Type 4 fracture. And when the growth arrest happens, it may result in various deformity of the ankle. If you have a fractured ankle and there's an anterior widening of the tibial physis, what causes this widening is the interposition of the periosteum. Two important fractures in the ankle. The low fracture occurs due to anterior-inferior tibiofibular ligament avulsion, and if the fracture is minimally displaced, as seen not only in the X-rays but in CT scan, you will do cast immobilization. If the fracture involves more than 2 mm of articular displacement, they are treated with open or closed reduction and fixation. So the question may come, what is the ligament that attaches to the fragment and causes the displacement? It is the anterior-inferior tibiofibular ligament. So why the low fracture occurs like this? Why is that small piece avulsed? It occurs because the lateral half of the distal tibia physis remains open. When you have an external rotational force, the anterior-inferior tibiofibular ligament holds the lateral part of the tibia that's open. The epiphysis will separate that part at the junction of the middle closed physis and the lateral open physis. The talus fracture commonly occurs in the 18 months before complete distal tibial physeal closure. This injury occurs with spination eversion mechanism. How about triplane fracture? Representation in the AP X-ray, there will be Type 3 Salter-Harris fracture with the fracture line extending into the ankle joint. In the lateral view, you will find Type 2 with a posterior metaphyseal piece. The triplane component fracture is a complex physeal injury that crosses the distal tibia physis in 3 different planes. So when you look at that triplane fracture and the talus fracture of the tibial growth plate, there's an explanation for them. That the tibial growth plate fused over 18 months, first in the central region, then posteriorly, then medially, and the lateral part closes last. The triplane and the talus fracture occurs during this period, and the general treatment is restoration of the articular congruity to decrease the incidence of post-traumatic arthritis. Thank you very much. I hope that was helpful.